Hi, and welcome back to Ready, Set, GYO, your on-the-go guide to learning gynecologic oncology. I'm Sydney.
And I'm Maya. This is a podcast for fellows by fellows. We are here to help you explore the diagnosis and treatment of gynecologic cancers, master the standards of care, and stay on top of new practice-changing publications.
Let's get ready to GYO! Greetings, Pod Squad. Today we're going to be discussing the evaluation and management of advanced stage vulvar cancer. Maya, what are our learning objectives for today?
Our learning objectives are to describe the evolution of the evaluation and management of locally advanced vulvar cancer, to discuss the utility of chemoradiation versus radiation alone in the primary treatment of locally advanced vulvar cancer, to review data on systemic therapies for metastatic vulvar cancer, discuss biomarker-directed therapies for vulvovaginal cancers, and to describe treatment options for progressive and recurrent vulvar cancer.
Great. Let's get started. Locally advanced vulvar cancer is defined as disease which is unresectable without removing the proximal urethra, bladder, or anus. Historically, these tumors were treated primarily with surgeries including en-bloc radical vulvectomy with bilateral inguinofemoral lymphadenectomy or pelvic exoneration. These procedures involved high surgical morbidity, and with time, this practice has changed to an approach involving radiation and chemotherapy. Maya, does everyone get the same chemoradiation treatment for locally advanced vulvar cancer, or are there factors to be considered?
Great question. When there's suspicion for locally advanced vulvar cancer, imaging should be performed. In radiographically negative nodes, it's reasonable to proceed with EBRT and concurrent platinum-based chemotherapy to the primary tumor, inguinofemoral lymph nodes, and to the pelvic lymph nodes, versus performing an inguinofemoral lymphadenectomy. The decision between the two management options is dependent on patient factors. If an inguinofemoral lymphadenectomy is performed and the nodes are histologically negative, then radiation to the lymph nodes may be omitted. If lymphadenectomy is not performed, then radiation to the nodal basins must be included. Conversely, if the inguinofemoral lymph nodes are radiologically suspicious, one could consider a fine needle aspiration of the enlarged lymph node or a full inguinofemoral lymphadenectomy for histologic confirmation. If the nodes are deemed to be unresectable, regardless of stage, imaging should be performed to assess the extent of disease. A fine needle aspiration can be considered for enlarged lymph nodes. These patients should be offered EBRT and concurrent platinum chemotherapy to the primary tumor, inguinofemoral lymph nodes, and pelvic lymph nodes. Sydney, what do we do after initial treatment of locally advanced disease?
You should evaluate their response. If a patient has a clinical complete response, biopsy should be considered to confirm complete pathologic response. In fact, in GOG 205, which we will further discuss in a moment, 22% of patients with a clinical complete response did not have a pathologic complete response. If there is both clinical and pathologic complete response, the patient enters into surveillance. If their disease remains clinically positive or pathologically positive and is resectable, then a surgical resection should be performed. If negative margins are achieved, this patient enters surveillance. If there are positive margins, then additional surgical resection, EBRT, and/or systemic therapy or best supportive care should be offered. Lastly, if a patient has clinically positive unresectable disease after primary chemoradiation, EBRT and/or systemic therapy or best supportive care are options. Mirroring our locally advanced cervical cancer episode, I'm curious, how did we arrive at treatment with chemoradiation versus radiation alone in vulvar cancer?
So in 1998, a phase 2 study, GOG 101, was published. It included 73 patients with clinical stage 3 to 4 squamous cell carcinoma of the vulva. Each patient received cisplatin and 5-FU with radiation in a split course, followed by radical surgical excision of residual tumor and bilateral inguinofemoral lymphadenectomy. 7 patients ultimately did not receive surgery after chemo-RT, and 46.5% had no visible disease. Only 2.8% of the initial cohort had residual unresectable disease, and only 4% were not able to preserve urinary or GI continence with surgery after chemoradiation. Montana et al. Published a subgroup analysis and follow-up of GOG 101 in 2000, investigating patients with N2, N3, or unresectable nodes to determine whether chemoradiation would increase the rate of resectability of the nodes. 46 patients were included, 4 of which didn't complete chemoradiation and 4 of which did not end up undergoing surgery, either due to death or persistent unresectable nodes. Out of the 40 patients who finished chemoradiation and were able to be evaluated, 38 had resectable nodes. Of the 37 who underwent lymph node dissection, 15 had pathologically negative specimens. Local control of nodal disease was achieved in 36 of 37 patients. 19 patients developed a recurrence, 9 had a primary recurrence, 8 had distant disease, and 2 had a mixed presentation.
Hahn et al. In 2000 published a small case series of 54 patients with locally advanced vulvar cancer who received chemoradiation versus radiation alone in both primary and adjuvant treatment. OS and PFS were significantly improved in the primary group treated with chemoradiation versus radiation alone. In the adjuvant group, there were trends favoring the chemoradiation group, but this was not statistically significant. This study was underpowered as there were only 6 people in the study who received adjuvant chemoradiation. In 2012, GOG 205 was published assessing the efficacy and toxicity of chemoradiation in achieving a complete clinical and pathological response. One limitation of GOG 101 was that recurrence rates were relatively high. When evaluating the study protocol, radiation doses were purposefully lower than normal to decrease toxicity, and there was a treatment break in the middle, the split course dosing. 58 patients with stage 3 to 4 disease not amenable to surgical resection were included. They were treated with cisplatin EBRT, followed by surgical resection if there was residual tumor, or no further treatment if there was a biopsy-confirmed complete response. Inguinofemoral lymphadenectomy was performed if the groin nodes were considered unresectable prior to chemoradiation. 69% completed treatment. 37 patients had a complete clinical response, and 34 of those underwent biopsy to confirm pathologic response. 78% of those with biopsy also had a complete pathologic response. This study suggested that the combination of cisplatin and RT at a higher dose led to high clinical and pathologic response rates that may eliminate the need for further surgical intervention.
Noddison published an NCDB analysis in 2017 of more than 2,000 patients with locally advanced vulvar cancer who had received either primary radiation or chemoradiation versus preoperative radiation or chemoradiation followed by surgery. Overall, those who underwent surgery after chemoradiation had a longer OS than patients treated with primary radiation or chemoradiation. However, in a subgroup analysis of patients receiving chemoradiation alone versus chemoradiation plus surgery, the overall survival was not significantly worse if the dose of radiation was more than 55 gray. Ultimately, use of chemotherapy was statistically significantly associated with improved survival. Rao et al. Published a retrospective NCDB study in 2017 evaluating patients who were not candidates for primary surgery, who received either primary chemoradiation or radiation alone. There were 999 patients in the chemoradiation group versus 353 in the radiation alone group. The chemoradiation group had more advanced disease and was younger. Notably, chemoradiation was associated with a significantly longer 5-year overall survival of 49.9% versus 27.4%, with a hazard ratio for death of 0.76.
Now on to our most current literature. This past year, in 2024, GOG 279 was published. It was a phase 2 trial of cisplatin plus gemcitabine plus IMRT for locally advanced squamous cell carcinoma of the vulva. The purpose was to assess the safety and toxicity of cisgem with IMRT given to a total of 64 gray. Patients were included if their disease was not amenable to surgery by radical vulvectomy. Each patient underwent an inguinofemoral lymph node assessment by full lymphadenectomy or sentinel lymph node biopsy. chemoradiation was combined with cisplatin 40 milligrams per meter squared and gemcitabine 50 milligrams per meter squared. Radiation was delivered to the groin and to nodes if the nodes were positive or if there was significant involvement of the vagina, anorectal, or urethral regions, even if the nodes were negative. Higher doses were delivered if there were high-risk nodal features, including 3 or more positive nodes, extracapsular extension, and/or close or positive surgical margins. If there was a complete clinical response, then core biopsies were performed to confirm complete pathologic response. If complete clinical response was not achieved, then a radical resection of the remaining tumor was performed or additional chemoradiation was given. Of the 52 included patients, 81% completed the trial prescribed therapy. At a median follow-up of 52 months, 71% had a complete clinical response. Of the 9 patients that had clinical persistent disease, 4 of the 9 had pathologically negative specimens after resection. The 5 remaining patients with clinically and pathologically persistent disease died within 8 months of finishing therapy. Toxicities were similar to those reported in GOG 205 despite higher doses of radiation. Progression-free survival at 12 months was 74%, and overall survival at 24 months was 70%. In conclusion, the rates of clinical pathologic response were higher in this study than in prior GOG studies. It's unclear at this time if the mode, being IMRT, and higher dose delivery of radiation, or the addition of gemcitabine, or a combination of the two, were responsible for the improved outcomes. However, the authors addressed this question in their discussion, citing 3 studies by Barawal, Rishi, and Van Treist, which taken together suggest that elevating radiation doses to at least 64 Gray is important for clinical pathologic response, as opposed to boosting chemotherapy or using a non-platinum agent such as gemcitabine or capecitabine, which may increase toxicity without having much effect on outcomes.
Really interesting. So what about neoadjuvant chemotherapy? Has it been investigated in this disease site?
Some, but we don't have prospective trials. Kuhn et al. Published a retrospective single-institution review of cases undergoing radical vulvectomy. Out of 113 patients with stage 2 to 4 disease, 13 underwent neoadjuvant chemotherapy. All 13 received carbotaxol and bev or cis-taxol and bev. 9 had a partial pathologic response, and the other 4 had complete responses. All patients had negative surgical margins. 77% had evidence of inguinal node involvement prior to neoadjuvant chemotherapy, and 4 had residual nodal disease. The median follow-up was 23 months, and 3 of the 13 patients developed recurrence, resulting in 1 death. The takeaway from this study is that neoadjuvant chemotherapy may be efficacious, lead to more negative margins, and improve surgical morbidity. However, we will need a larger prospective trial to fully understand the conclusions. Are there any ongoing trials, Maya?
Yes, there are. And luckily, one of them may answer our above question. There's a multi-center prospective phase 2 trial by Amont investigating primary chemoradiation versus neoadjuvant chemo followed by surgery as treatment for locally advanced vulvar cancer. Other trials are investigating the addition of immunotherapy with pembrolizumab to primary chemoradiation.
Awesome. I think that rounds out our discussion on locally advanced vulvar cancer. What about metastatic disease, stage 4B?
Generally, systemic therapy is offered, although the data is limited and is often extrapolated from cervical cancer. In fact, there are no prospective trials for first-line chemo for patients with metastatic vulvar cancer. That being said, for patients with stage 4B disease that is limited to the pelvic lymph nodes, definitive chemoradiation with curative intent may be offered. One can also consider EBRT for local regional control or symptom management, or even ablative therapy for 1 to 5 metastatic lesions if the primary tumor has been controlled. Best supportive care is also an option. A systematic review by Reed et al. Was published in 2014, which identified 5 studies that had prospectively evaluated systemic therapies for advanced or metastatic vulvar cancers. 3 studies using cisplatin alone, piperazine alone, and methoxantrone alone in small series of 11 to 22 patients all had 0% partial response and 0% complete response. Thus, as stated, we extrapolate our choices of systemic therapy from cervical cancer. So cisplatin and paclitaxel plus minus Bev is a preferred first-line treatment based on GOG 240. Similarly, carboplatin and paclitaxel plus minus Bev can be considered based on the non-inferiority trial of JCOG 0505.
Thanks. What should be done in the case of recurrence? Is it common?
Unfortunately, it is. In one case series, 37% of all patients with vulvar cancer developed a recurrence. When recurrence is suspected, whole body imaging should be performed to evaluate the extent of disease. A biopsy can be considered to confirm the recurrence. About 53% of recurrences will be confined to the vulva. The remaining percentage are accounted for by 19% inguinal recurrences, 14% multifocal, 8% distant, and 6% pelvic recurrences. There's differing 5-year overall survival by recurrent site, with a 60% 5-year overall survival for vulvar recurrence, 27% if you have an inguinal or pelvic recurrence, and 15% if you have a distant recurrence, and 14% if you have a diffuse or multi-site recurrence.
There isn't a standard of care for treatment of recurrences. It is individualized. If the recurrence is limited to the vulva with clinically negative nodes, radical excision is performed plus minus an inguinofemoral lymphadenectomy, and adjuvant radiotherapy with or without systemic therapy can be considered. For large or central recurrences, there is some evidence that exoneration can prolong survival. If there are negative margins achieved with surgical excision, observation or EBRT can be considered. If the margins are positive, re-excision, EBRT, or chemoradiation can be considered. Locoregional recurrences carry some different recommendations. Neoadjuvant chemotherapy, chemoradiation, or radiation alone are all options. If there is distant disease or the patient previously received EBRT, systemic therapy is recommended and 5-year survival, as stated, is less than 10%. Selective EBRT or supportive care can be offered. Unfortunately, prognosis with nodal recurrences is very poor, regardless of offered treatment. Maya, we went over first-line systemic therapy recommendations. What about in the second-line or subsequent scenarios?
If first-line systemic therapies like cis-taxol plus minus Bev or carbotaxol plus minus Bev haven't been used previously, then they can be used in this scenario. Woodavine in 2009 published a phase 2 study evaluating 3-week paclitaxel single-agent therapy in advanced vulvar cancer. 31 patients with advanced metastatic or recurrent vulvar cancer were included, and response rates were about 14%, with a median PFS of 2.6 months. Biomarker-directed therapies can also be used. In TMB high, PD-L1 positive, and MSI high or dMMR tumors, pembrolizumab can be considered. Keynote 158 was published in 2020, which included 101 patients with progressive unresectable vulvar squamous cell carcinoma. The overall response rate was 11%. In the 12 patients that had TMB high tumors, the overall response rate was 17%. The response rate was only 3.4% in TMB low tumors. 84% of the 101 patients were PD-L1 positive, and response rates were 9.5% in PD-L1 positive patients versus 29% in PD-L1 negative patients. That being said, the sample size for the PD-L1 negative patients was very small. The study showed efficacy in PD-L1 positive and negative tumors and suggested that PD-L1 may not be a great marker for response in this patient population. In addition, previous studies have reported much lower rates of PD-L1 positivity among vulvar cancers, like less than 30%, and PD-L1 positivity is associated with a worse prognosis. The study included previously treated patients, which means that they were a worse prognostic group, so the sample may have had a higher rate of PD-L1 positivity than the whole population with vulvar cancer. The median PFS was 2.1 months, and the median overall survival was 6.2 months. This result was similar to prior studies in advanced vulvar cancer, although most other studies didn't include patients that had received prior treatment.
There are some additional basket studies with low sample sizes for vulvar cancer that we should mention. Checkmate 358, published in 2019, investigated the use of nivolumab in HPV-positive or HPV-unknown cancers. There were 5 patients with vulvar or vaginal cancer with a 12-month overall survival of 40% and a 6-month progression-free survival of 40% as well. The Destiny Pan-Tumor Phase 2 trial, published in 2024, investigating trastuzumab deruxtecan in HER2-positive tumors, only included 1 patient with vulvar carcinoma, and thus outcome results are extrapolated from uterine and cervical cohorts. Lastly, larotrectinib or entrectinib can be used for tumors with an NTRK fusion, expressed in only 0.3% of solid tumors.
Additional options for systemic therapy include cemiplimab, with data extrapolated from efficacy in cervical cancer. Remember the Empower Cervical 1 trial, and advanced cutaneous squamous cell carcinoma. Erlotinib, a tyrosine kinase inhibitor, can also be considered. Horowitz et al. Published a phase 2 study of erlotinib in 41 patients with squamous cell carcinoma of the vulva. The response rate was 27.5%, but the responses were of short duration, with a median duration of response of only 28 days. Cisplatin with gemcitabine or cisplatin with vinorelbine can also be considered, although the latter isn't included in the NCCN recommendations. Overall, systemic therapy for vulvar cancer needs further investigation, specifically in older patients more than 70 years old, as the average age for diagnosis of vulvar cancer is 69 years. So let's end on a more positive note. What about surveillance after treatment and survivorship concerns?
Most recurrences of vulvar cancer occur within 1 to 2 years, but they can also occur remotely, meaning beyond 5 years from original treatment. Thus, long-term surveillance is needed. Patients should have a history taken and physical exam every 3 to 6 months for 2 years, then every 6 to 12 months for another 3 to 5 years, and then annually. More frequent assessments are reasonable for patients with high-risk disease. Post-radiation care is really important, as previously discussed in our radiation toxicities and locally advanced cervical cancer episodes. Patients should be educated on dilator use, vaginal moisturizers or lubricants, and/or estrogen creams after radiation. It's also important to monitor for secondary radiation-induced cancers. Lastly, remember to ask all of your patients about genitourinary symptoms like vulvovaginal dryness or irritations, regardless of sexual activity. That's all we have for you today. Maya, what are our takeaways?
Locally advanced vulvar cancer describes disease that is unresectable without removing the proximal urethra, bladder, or anus. Historically, these lesions were treated surgically, involving primary exenturations and disfiguring surgeries. Over time, treatment options have shifted to prioritize preservation of important anatomic structures and quality of life, moving towards radiation with or without chemotherapy.
Based on retrospective data and small case series, chemoradiation versus radiation alone appears to have a survival advantage in locally advanced vulvar cancer. Prospective trials on chemoradiation include GOG 101 and GOG 205, which both evaluated chemoradiation. GOG 205 increased the dose of radiation, avoided treatment delays and treatment breaks, and was able to achieve a higher complete response rate and lower recurrence rate. In recent years, a couple of phase 2 trials have evaluated other chemotherapies, including capecitabine and cisplatin with gemcitabine, and advanced radiation techniques like IMRT, and have demonstrated promising results with these therapies. Ongoing trials are evaluating the use of neoadjuvant chemotherapy and incorporation of immune checkpoint blockade.
Data on systemic therapies in advanced vulvar cancer is extremely limited, and much of what we use is extrapolated from cervical cancer research. First-line preferred therapies include cis-Taxol or carbotaxol with or without bevacizumab, based on extrapolated data from GOG 240 and JCOG 0505. Prospective studies in vulvar cancer with different agents have not yet yielded promising results.
Immune checkpoint blockade is currently recommended for vulvar carcinomas that have progressed on primary therapy. Pembrolizumab is recommended for patients with TMB high, PD-L1 positive, or MSI high dMMR tumors based on results of the KEYNOTE-158 trial. Notably, in the Vulvar cohort of this trial, PD-L1 expression was not predictive of response, and responses were seen in both PD-L1 positive and negative tumors. Nivolumab was studied in CheckMate 358 for HPV-positive tumors and HPV-unknown tumors, and the use of cemiplimab is extrapolated from the EMPOWER trial in cervical cancer. Other directed therapies such as HER2, Intrec fusion, EGFR, and BRAF-targeted therapies should be considered on an individual basis in molecular profiling.
Treatment of recurrent and progressive vulvar cancer is not standardized, and options depend on the location and extent of disease. If localized, surgery with radical vulvectomy plus/minus lymphadenectomy or exenteration could be considered. Radiation can be considered depending on previous radiation history and could be added after surgery or with chemotherapy. Systemic therapy is recommended for distant disease or for patients with prior radiation. Systemic therapy options include targeted therapies, use of first-line chemotherapy options if not used previously, or single-agent cytotoxic therapies. Prognosis for distally recurrent or nodal-involved disease is poor. This has been another episode of Ready, Set, GYO, your source for all things gynon.
If you'd like to check out today's show notes, take some practice questions, or explore resources we use to create the podcast, head to readysetgyo.com, the companion website for our podcast. We encourage you to reach out if you have ideas for new episodes, questions or comments about existing episodes, or thoughts of how we can make this podcast even better suited for you. We're excited to continue to learn with you.
To stay up to date on all things Ready, Set, GYO, check out our Instagram and Twitter at ReadySetGYO.
To support us and our production of future episodes, check out our Patreon at ReadySetGYO.
This episode was recorded by Sydney Oesch and Maya Gross. Our sound editors are Brogan Brown and Kylie Knight. Our media and website manager is Sky Jacobson.
We'd like to thank Dr. Jessica Parker-Metter, faculty at Indiana University Health, who reviewed the content of this episode for accuracy and completeness. Sydney and Maya signing off.